Hello everyone and welcome to our module on public health. Lots of public health efforts are aimed at disease prevention, so let's talk about the different types of disease prevention. We'll start by talking about primary prevention. So primary prevention refers to strategies that aim to prevent disease from occurring in the first place. So the classic example of a public health measure for primary prevention is immunizations. Immunizations are given to healthy individuals like this baby on the screen here, and the idea is to prevent the baby from ever getting sick in the first place. Another example is folate supplementation in women who are pregnant. We advise pregnant women to take folate so that their babies will not be born with neural tube defects. So for any prevention program, if the goal is to prevent disease from developing in the first place, then that's considered a primary prevention program. In contrast, secondary prevention programs aim to detect disease early and prevent patients from becoming severely ill or possibly dying from disease. So the goal of secondary prevention programs is to prevent disability. These programs try to detect and treat disease early, ideally when the patient is asymptomatic. And so most of the screening programs we have in medicine are examples of secondary prevention. For example, this is a mammogram shown on the screen here, and the goal of mammograms is to identify breast cancer early so it can be treated before it has spread and becomes life-threatening. Pap smears are another example of secondary prevention. They aim to detect human papillomavirus infection before it leads to cancer. Colonoscopy is also another example of secondary prevention. The goal here is to detect colon cancer early when it can be treated. So in general, programs that aim to detect disease very early, ideally when the disease is asymptomatic, and prevent the disease from getting worse, those are usually examples of secondary prevention. The goal of tertiary prevention programs is to prevent long-term disease complications among patients who have already developed a significant degree of disease. The goal here is usually to maximize the remaining function of the patient or the diseased organ system. So for example, cardiac or stroke rehabilitation programs are examples of tertiary prevention. These programs are for patients who already have a significant burden of cardiac or neurologic disease, but the program tries to rehabilitate the patient to maximize their remaining function. And hopefully you can appreciate that this is different from secondary prevention, where we're trying to detect disease at an early stage. In a cardiac or stroke rehabilitation program, disease is already far beyond the early stages. It's in a more advanced stage, but we're trying to maximize the remaining function for the patient. Support groups for many diseases are also examples of tertiary prevention. They aim to support patients at staying well and not having exacerbations of their disease. And then many forms of chronic disease management, where we treat patients who have a chronic disease and our goal is not to cure them but to keep them from getting worse. Those are often examples of tertiary prevention. And then finally, quaternary prevention is a unique form of prevention aimed at preventing overtreatment of patients, basically preventing patients becoming harmed by treatments being used inappropriately. So in U.S. medicine, there are many examples of overuse. For example, compared to many other countries, we do more blood tests in the United States, more radiology tests, more coronary procedures. There are lots of examples of tests and treatments that we use to a greater extent than may be necessary. So sometimes a quaternary prevention program will be launched related to one of these types of things shown on the screen here, and the goal of the program is to ensure appropriate use of the test or treatment and make sure that patients are not overtreated and harmed by being treated when they don't need the treatment necessarily. Let's talk about how the U.S. healthcare system works. So healthcare is very expensive. Most medications and visits with doctors and surgeries cost hundreds and thousands of dollars and even more. So very few patients pay out of pocket. Most patients have some form of insurance which pays for their health care. And there are three major categories of insurance options that patients have in the United States. The first is Medicare, the second is Medicaid, and the final option is private insurance. Let me mention a brief word on emergency care. In the United States, emergency care for life-threatening illness must always be provided regardless of a patient's insurance status. When a patient comes to the emergency room, they are always treated whether or not the patient has insurance or an ability to pay for their care. After the patient is stable, a discussion can be held about whether or not the patient has insurance and how they're going to pay for their care, but we never worry about those things when the patient first walks through the door. We always treat them first, no matter what their insurance status or ability to pay may be. So now let's talk about the major forms of health insurance in the United States, and I'll start by discussing Medicare. So Medicare is a federal program administered by the U.S. government. This means that if you live in the state of California or you live in the state of New Mexico, you don't get Medicare from your state. You get it from the U.S. federal government, the government of all the states in the United States of America. Medicare is funded by federal U.S. taxes, and it provides insurance for patients that fall into certain groups. The major group that receives insurance through Medicare are patients over 65 years of age. Medicare also provides insurance for patients who are disabled, and then finally it provides insurance for all patients on dialysis. Many years ago in the United States, it was decided that we wouldn't allow patients to die because of inability to pay for dialysis. So if any patient needs dialysis for chronic kidney disease, they automatically qualify for Medicare insurance. Medicare is broken down into several parts. Medicare Part A is what makes payments to hospitals for patient care. So if a patient covered under Medicare is admitted to the hospital and receives treatment, the hospital will be paid by Medicare Part A. Medicare Part B provides payment for outpatient treatment, for example, treatment in doctor's offices. So this is things like clinic visits and outpatient diagnostic testing. And then Medicare Part D provides insurance for prescription drug coverage. And then Medicare Part C is a special option that a patient may choose to select if they wish. And for patients who select to be covered by Medicare Part C for their health insurance, the government pays a private insurer, and then the private insurer provides health care to the patient. This option was added into U.S. law many years ago when some patients wanted to have private insurance and wanted to not be covered by the Medicare program directly. So this allows patients to have private insurance, and the private insurance is paid for by Medicare under Medicare Part C. The other major government-run health insurance option in the United States is Medicaid. So Medicaid pays for health care with money that comes jointly from state and federal governments. Some of the money to pay for Medicaid insurance comes from the federal government and some comes from the state governments. Now, even though the money comes from a mixture of the state and federal government, Medicaid is administered by the states. So for example, if a patient lives in the state of Florida and qualifies for Medicaid, they will receive their Medicaid insurance from the state of Florida, administered by the state of Florida, even though the money comes from a mix of money from the federal government and the government of the state of Florida. And the way patients qualify for Medicaid insurance in the United States is generally based on income. Medicaid provides health insurance to low-income patients and families in the United States. So in the United States, if you're over 65 or disabled or on dialysis, you qualify for Medicare. If you come from a low-income family, then you qualify for Medicaid. But for all the rest of the people who don't meet any of those qualification criteria for Medicare or Medicaid, they get their health insurance through private insurance. So private insurance is called private insurance because it's provided by private companies. A person pays the company, and then that company covers the patient if they get sick and need advanced care that's expensive from a doctor or in the hospital. And you should know that in the United States, very few people pay directly for their private insurance. Often the insurance is paid by the patient's employer. The way this works is the employer pays a fee to the insurance company, and then the insurance company agrees to pay the costs of medical care for all the employees of that employer's operation. Now, it's very expensive for employers to do this, but in the United States, many employers do this because it helps to attract skilled workers. Highly skilled workers are more likely to come and work for a company if they know that they're going to get health insurance compared to if the company does not provide health insurance. And so for patients in the United States who have private insurance, either because they've bought it for themselves or because their employer paid for it, there are several types of private insurance plans that patients can have, and they vary based on the features and the cost of the plan. And the three types of plans are an HMO plan, a PPO plan, and a POS plan. And we'll talk about all three of these in the next few slides. An HMO is a health maintenance organization. It's basically an insurance company that provides insurance to patients for their health care, but also the insurance company hires providers. So HMOs will pay a salary to physicians, and the physicians become employees of the insurance company that is an HMO. If you're a patient and your health insurance is an HMO, then you have to go to HMO providers for your care. You have to go to those doctors who are employees of the company. This limits the choice of physicians to patients. The upside of an HMO, however, is that it tends to be less expensive compared to other insurance models. Because the doctors are employees of the insurance company can control what drugs they prescribe and what tests they order, and this allows the company to limit costs. And so this makes these types of plans less expensive to the patient, even though they're more restricted in terms of a limited choice of physicians and what the physicians can order in terms of tests and treatments. A preferred provider organization, or a PPO, is a health insurance arrangement where a patient can see any physician they wish and the insurance company will pay for the evaluation. There are, however, incentives to the patient to go to certain physicians who are in-network. These are physicians where the cost to the PPO is lower, so the PPO tries to encourage patients to see these physicians rather than out-of-network physicians. And the way they incentivize patients is through a copay. So when patients in a PPO go to a physician, they have to pay a small amount of the fee. This is called a copay. And the copay is lower or sometimes zero if the patient goes to an in-network physician. The copay is higher if the patient goes to an out-of-network physician. A PPO is a more expensive plan compared to an HMO because the PPO doesn't employ the physicians and therefore isn't as able to limit what the physicians order and prescribe, and this makes it harder to control costs. PPOs are very popular, however, because they're very flexible. Patients like them because they don't have to go to a doctor who's employed by the health insurance company. They can go to any doctor they wish. The only difference is they pay a slightly higher copay if they go out of network. And then a point of service, or POS plan, is a middle option between the HMO model and the PPO model. A POS plan is sometimes called a gatekeeper model, and it gets this name because the patient has to choose a POS plan primary care doctor who will serve as the gatekeeper to additional care for the patient. So similar to an HMO, the patient has to choose a primary care doctor that works for the point of service plan, and this primary care doctor authorizes care to additional physicians, and that's why this person is called a gatekeeper. Once the patient selects a primary care doctor to serve as gatekeeper, the patient can have visits with other physicians, but they require a referral from that gatekeeper primary care doctor. And then referrals can be made, much like in a PPO model, to physicians who are either in-network or out-of-network, and the copay will differ depending on whether the referrals are made to in-network or out-of-network physicians. So when patients have health insurance, whether it's Medicare or Medicaid or some type of private insurance, that insurance company has to pay doctors and hospitals for care of patients. So let's talk about some of the different types of payments that insurance companies make to doctors and hospitals. The easiest type to understand is fee for service. For example, an insurance company might pay $100 per clinic visit or $1,000 per surgical operation. And this is called a fee for service model of payment for insurance company payments to doctors or hospitals. Doctors are sometimes paid a salary. I mentioned this earlier when talking about HMOs. So some insurance companies hire doctors and pay them a salary, like $100,000 per year. And then in exchange for this salary, the doctor has to see all the patients of the insurance company that need to be seen by that doctor. And then another model for payments from insurance companies to either physicians or hospitals is called capitation. In this model, the insurance company gives a set fee, a set dollar amount, to the doctor or the hospital for each patient or illness that they're going to treat. So for example, when patients come into the hospital with heart failure, Medicare will pay the hospital a set fee of $10,000 or $15,000 or something like that. If the hospital spends less money than that fee taking care of the heart failure patient, then the hospital makes money and makes a profit. If, on the other hand, the hospital spends more money caring for that heart failure patient and exceeds the set capitation fee, then the hospital loses money and does not make a profit. So the idea behind capitation is that the financial risk is transferred to the physician or hospital, and depending upon how much money is spent taking care of that patient or treating that illness, then that will determine whether or not a profit is made. One of the problems in U.S. healthcare is that in many cases it incentivizes quantity of care over quality of care. There are a lot of financial incentives to order more tests and perform more surgeries, but there are far fewer incentives to make sure that those tests and those surgeries benefit the patient. So in order to address this, the Institute of Healthcare Improvement came out with its triple aim for healthcare, and you should be familiar with this term. And the triple aim says that the goal of healthcare should be to improve the patient's experience of care, improve the health of populations, and reduce the per capita cost of healthcare. And so the idea behind this triple aim is to try and move away from paying for quantity of healthcare and try to start paying for quality of healthcare. One of the ways U.S. healthcare has tried to work towards the triple aim is by encouraging the formation of accountable care organizations, or ACOs. ACOs are groups of healthcare practitioners, for example, physicians and nurses who practice in the community, and they voluntarily join together and agree to receive payments from third-party payers like Medicare and Medicaid and private insurers. And the groups are held accountable, and by this I mean that they agree to receive payments for the care they deliver based on quality metrics. So for example, if a group of doctors and nurses in the community form an ACO, that ACO might get higher payments for the care they deliver if a high percentage of the patients who are cared for by the ACO receive vaccinations. Or they might receive higher payments if a high percentage of the diabetic patients receive eye exams. But the idea here is to try and incentivize payment for high quality of care instead of just high quantity of care, which is the way healthcare in the U.S. has traditionally been. Another way U.S. healthcare has tried to move towards the triple aim is by encouraging the formation of patient-centered medical homes. The idea behind a medical home is to have a team of care providers for each patient, not just a single primary care doctor. So this team might include doctors, nurses, social workers, pharmacists, and they all work together to provide coordinated care for patients and families. Because it's a team and not just one doctor, it's meant to be more accessible so patients can be seen after hours or on weekends. And the group is committed to providing high quality and safe care to the patient. And so many of the payers in U.S. healthcare, like Medicare and private insurers, encourage the formation of patient-centered medical homes. And if doctors and nurses and social workers set these up, they can receive bonus payments for caring for patients in a medical home model. And once again, the idea is to move healthcare towards paying for quality and safety rather than just paying for quantity of care. Let's talk about palliative care. So palliative care refers to specialized medical care for patients with serious and usually advanced illnesses. So palliative care is often used in the treatment of patients with cancer, but also other illnesses like CHF and COPD, dementia and stroke, and others. And what makes palliative care different from traditional U.S. medical care is that the focus in palliative care is strictly on improving the quality of life, not extending life. So palliative care has a strong focus on symptom management, but palliative care doesn't include things like surgery to remove a tumor or lowering the blood pressure, because these things are aimed at prolonging life. Now, palliative care can be provided alongside curative medical treatments aimed at life prolongation, but the focus of palliative care is going to be symptom management. Things like pain and nausea, vomiting, anxiety and stress, these are all classic elements of the focus of palliative care. Often palliative care is a team approach, especially in the hospital. Many hospitals have palliative care teams that consult on patients with serious illnesses. Members of the team can include a physician and a nurse, social workers, and even others like priests or clergy or practitioners of mindfulness and meditation. Palliative care is called primary palliative care when it's provided by the patient's regular doctors, and it's called secondary palliative care when a specialist in palliative care helps deliver the care. And there are specialists in the U.S. trained in palliative care. Many of them do a fellowship, and you can even become board certified in hospice and palliative medicine. And so that's a nice segue into hospice care. So hospice is a subset of palliative care at the end of life. Hospice services are provided at home or in a facility. They focus on symptom management, and we only deliver hospice care to patients with an expected survival of less than 6 months. And this number of less than 6 months often comes up in your board exams. And then I'll finish with this one slide that illustrates the ideal way to integrate palliative care and hospice care into the best care possible for the patient. So on the y-axis we have the percent of focus of healthcare, and on the x-axis we have time. And so initially, when caring for patients with serious illness, the focus is mostly on curative care. But as the illness progresses over time, more and more the focus becomes palliative care. And as I said, palliative care can be provided alongside curative care for patients with serious illnesses. When the illness becomes very advanced and the patient is within 6 months of death, then the patient transitions to hospice care, which consists entirely of palliative care and not curative care. And then ideally, if you're delivering the best care possible to patients and families, even after the patient dies, You provide death and bereavement care to the family who has lost their loved one. And that concludes our module on public health.